under the aegis of uh, Association of Physical Medicine Rehabilitation of Odisha and Indian Association of Physical Medicine and Rehabilitation. This webinar is meant for young physiatrists and PG students for academic discussion. Friends, we all of us are dealing with spinal cord injury patients as indoor patients or outdoor patients. And the most common question asked by the patient or by the caregivers is that whether my patient will walk or not. That's a very difficult question to answer, whether he'll walk or not. So on that uh, queries of patients and the about the mobility of a patient with spinal cord injury. Today we have with us Dr. Sanyal Kumar. He is the assistant professor of AIIMS Patna. He will speak on enhancing mobility, strategies to restore and promote uh, walking function following spinal cord injury. So before going to the topic, let us have a brief discussion about the today's speaker. He is Dr. Sanyal Kumar. He is assistant professor of PMR at AIIMS Patna. Being a young physiatrist, he has a lot of academic interests, which is well shown on his CV. He has around 26 index publications, he has 3 projects, and his organizing capacity is shown by as his capacity as uh, assistant or co-organizing secretary in various state conferences of Bihar, and he has also a lot of award to his credit. He has got KK Memorial Best Faculty Award, WG Ramarao Travel Fellowship Award, and Bihar Health Icon Award. So, welcome Dr. Sanyal Kumar for today's webinar. I hand over the podium for your presentation from your side. Thank you. Over to you.
Thank you so much, sir, for giving my introduction in a short nutshell. So, and I am very much thankful to IAPMR, APMRO, and Department of SVNIRTAR who gave me the chance of sharing my thoughts in this academic platform. So, I am, sir, my slide is audible now.
Yes, your slides are visible and you are well audible.
Okay, okay, thank you, sir. So, before we starting, uh, various conditions, we know that after spinal cord injury, most of the patients know that when patient come to our OPD, IPD, and various rehabilitation setting, the caregivers and patient itself talk about as my patient is able to walk or not. So we are in the dilemma to answer these questions. So here, before I'm going into depth, my topic is enhancing mobility strategies to restore and promote walking function following spinal cord injury, and focus on these 3 parameters: who walk and how walking is generated and why walking is important in spinal cord injury patients. So uh, just I'm said say that if a patient with spinal cord injury came to our OPD or IPD setup, their caregiver and patient in himself talk about is able to walk in future or not. So we can share their with the help of uh, like our clinical expertise as well as international standard of neurological classification of spinal cord injuries and Asia level and their neurological level, we can say that your patient is maybe able to walk or not even. But
Dr. Sanyal, sorry
yes,
for interruption.
yes,
Can you please make your slide as slideshow mode?
okay, okay, sorry, sir. Okay, okay.
Yes,
So,
it's fine now. It's fine.
okay, okay. So here there is a two prediction model through we can predict in a future of that spinal cord injury patient can walk after within 1 year of post injury. So these two prediction model, one is coined by the Minder-Drop et al. Through 5 variable prediction rule, but it shows it doesn't have high area under cover. So it's not much more efficient method to predict. So other is other three other model of prediction is coined by the Higgs et al. It's basically provide the 3 variable prediction rule. This clinical prediction rule based on the measure of using INSI, means International Standard of Neurological Classification of Spinal Cord Injury, within 15 days of admission. So prediction rule score, this is the equation through which we can predict. So let's start with how we prediction model and variable and its coefficient. So if a patient, these three variables like age, if a patient have age more than 65 or equal to 65, we assign -10. Otherwise, we assign 0. If motor score at L3 level is ranging between 0 to, it is multiplied by 2, and light touch in the area of S1, it is multiplied by 5. So total score is sum of these weighted value, and it ranges from -10 to 20. The higher the score means higher likelihood of independent walking. So here in the right side of corner, there's the example. Like if a spinal cord injury patient 50 year. So according to this, we have assigned here is a 0. So L3 motor score, let's assume there is a 4 in L3 level, and S1 light touch score is 2. So total score is 18 when we calculated all these three. So calculate the exponent. We put this value in our this prediction rule equation and compute this. Come with the value of 2.373. Now we all have very well aware of about scientific calculator, which is generally inbuilt in our smart mobile. So we can put this exponent value in this figure of this, which shown is left lower corner. So after this computed, we compute this into 10.73. Same, we calculate the denominator. After calculating this denominator, we compute the probability after dividing these two values. So we calculate 0.95, and after percenting it, it is come into 91.5%. So what interpretation it seems to it? So this patient having this some sort of this clinical values, so 91.5% likelihood of independent walking suggests a strong probability that the individual will walk independently within 1 year post injury. The probability exceeds the cutoff of 0.5. Now talk about the another example. If a bilateral score is different, so let us assume if a patient is 60-year-old and L3 motor score right side is 3 and left side is 2. So and S1 there's the right side is 1 and left side is 2. Then use the better score in sensory as well as motor. Now we calculate the similar fashion, and now after computing the probability, it's come 87.5. What interpretation? 80 the patient, our assumed patient is 87.5% of likelihood of independent walking suggests a strong probability that the individual will walk independently within 1 year post injury. Okay. Now, sorry. How walking is generated? We all know, or we all aware that walking is generated by all the neuronal circuit through connected with the brain, cerebellum, brainstem, and spinal cord. And in the spinal cord, there is a central pattern generator which produces the locomotor output. Various systemic review concluded that there is a repetitive movement and exercise can stimulate and reorganize the neural circuit which involved in the motor control, including the central pattern generator. So why walk? These two aspects. One is a positive aspect in a spinal cord injury patient, and one is a negative aspect. What are the positive aspects? Is the first is the physiology. We know that spinal cord injury is chronically bed bounded, so there is a lot of physical, biochemical deterioration is there. So if a patient of spinal cord injury, even we provide is body weight supported treadmill, so there is an improvement in the cardiovascular health, improvement in the muscle composition, but the various systemic review done, but not they didn't conclude the evident that there is a decrease in the fat mass or increase in the fat mass or increase in the bone mass. It's also improved their psychological benefit, which enhance psychological well-being and health-related quality of life, improve body image and self-perception, increase life satisfaction and independence, reduce pain-related distress and uplift mood. Standing upright offer emotion and mental health benefits. So, negative aspects of these two is a high metabolic cost. So, every spinal cord injury generally work with a slow speed with walking aids. For a normal walking speed for indoor mobility, generally it's ranging from 0.15 plus minus 0.08 meter per second. For outdoor, its ranges from 0.44 plus minus 0.14 meter per second. For in a spinal cord injury, we say that the O2 consumption is also high. Here we give the some example. The able-bodied person generally O2 consumption is 10 to 12 ml per kg per minute, and here we see that wheelchair propulsion, its consumption is quite less as compared to able-bodied person, and higher O2 consumption those who use parastep or functional electric stimulation. Okay. So there are the two pillars of locomotor recovery in SCI. One is the locomotor training and other is the gait training. Locomotor training is repetitive practice intended to activate the neural locomotor centers. And gait training is instructed in the use of stepping pattern and assistive devices. So what are the clinical integration of locomotor training? Which basically based on the upper use dependent plasticity for restoring function, improve walking speed, distance, limb coordination, and muscle activation, enhance strength, balance, and reduce energy expenditure, and also improve the sense of well-being. So principles behind it, it's promote upright posture with good trunk extension, encourage weight bearing on the lower extremity, approximate normal walking speed during training, and maintains normal hip, knee, and ankle kinematics, and encourage arm swing with normal reciprocal upper limb and lower limb. So there is a various methods of locomotor training. So one is the overground locomotor training, another is body weight supported overground training, assistance for stepping during overground training, treadmill based locomotor training, manual assisted stepping, robotic exoskeleton assisted stepping, and stimulator assisted stepping. So overground training. So overground training is more accessible form and patient practice in a real world environment. So engage is the neural mechanism of dependent plasticity and motor learning. We generally use exoskeletal device like KFO, HKFO, AFO, and some upper extremity aids or be used during the locomotor training of the overground. Another is the body weight supported overground training. So it is basically two types. One is mobile and other is fixed. It is a safe environment for practice and learning, uh, and also appropriate for the early locomotor training. The disadvantage of this body weight stability is postural control. So here we share these two pics. One is the Endago, uh, which is uh, which is Endago, and other one is NX step. I'm just highlighted the bracket of these two. Our young physiatrists who are going to be a faculty soon, are resident, senior resident who are going to be second faculty soon. They don't even know that from where we can approach, we can buy the better and effective. So these two company provide this body weight supported treadmill, body weight supported overground training instruments. Okay. Another is there is a various mobile, there is fixed body weight supported like load WBS 0G, which is provided by Aritech company, Vector, which is provided by Bionis, and other is assistance for stepping during overground training. So there is a electrical stimulation which activate the user own neuromuscular system to assist with stepping, most useful for those have relatively good hip and knee control. Dorsiflexor assist stimulation may modify spinal neurocircuit, resulting more normal reflex modulation. Metabolic cost is decreased as compared to the passive device. So these two functional electrical stimulation for dorsiflexor assist, like WOCAT, supplied by the Neurotronic company, and L300 bind, which is supplied by Bionis. So other method is the treadmill-based locomotor. Treadmill-based locomotor training is done under the control environment, which is combined with partial body weight, and assistance for stepping can be provided by the manual assistant, functional electric stimulation, orthotic or robotic lower extremity exoskeleton. So I'm here putting these some technical specification as a basic technical specification, which is required for the treadmill in a rehabilitation setup. You can we can you can just take a snapshot and modify according to your need. Okay. So other method is manual assisted stepping, which is most common approach. The drawback is which required multiple therapists, and therapists need external doing external work where the patient having significant weakness and spasticity. So other method is the robotic exoskeleton assistive stepping, most widely available, but not in India. It's safe training environment. I'm here putting some example of robots which is used in the rehabilitation. So there's a basically four types of robots which is used in rehabilitation. Is one is exoskeleton robots, another is end effector robot, assistive robots, and therapeutic robots. So exoskeleton robots is worn by the body, a joint level assistant, and effector is contact at distal end and movement from fixed point. Assistive robots is support daily tasks by mechanical assistant, and the therapeutic robots is deliver specific exercise therapy. The primary goal of exoskeleton robots is the gait and limb movement training, and the end effector robot is task specific movement rehabilitation. Assistive robot provide the primary goal is functional independence, and therapeutic robot is for the rehabilitative training. So uses is the exoskeleton can be used in the clinical as well as home-based use, and end effector mostly it's clinical and rehabilitation setting, and assistive both home-based and institutional-based, and therapeutic it's both home, it's basically institutional and rehabilitation center. The example of exoskeleton is locomote, ESCO, Rewalk, hybrid assistive limb, and Armio spring. Uh, and for end effector, this is LocoHealth, Amadio, InMotion, and assistive robot is JacoArm, IARM. The therapeutic robot example is hand tutor, mirror hand, and rehab devices. So here some pics of this exoskeleton robot is like Exosuit, Rewalk, Vanderbilt exoskeleton, Rex, and HAL. These are the Locomote and Amadio. So this is the Loco Help, which is end effector robot, Amadio and InMotion, which are the example of end effector robot. This is Jacko arm and I arm, pick off, and this is the hand tutor, mirror, and hand rehab devices. So last is the stimulator assisted stepping, manual assisted step training that provide externally generated decision, which stimulate the flexure withdrawal response that stimulate to activate the dorsiflexor, knee flexor, and hip flexor muscle, which is closely associated with central pattern generate circuit, but it is noxious. So we can't give the patient who have neurological level T at above T6 level. So generally, patient can land up into the autonomic dysreflexia. So gait training strategy in spinal cord injury, gait training which help people with spinal cord injury work better by using feedback form, therapists, and support device like braces. It focus on improving walking by adding balance aids and joint support. Even in full muscle control is not possible. Tools like motion sensor or therapist observation are used to check for the problem in walking movement. A spinal cord injury functional ambulatory inventory is a tool used to measure walking ability, support use, and how far and how fast a person can walk. Overall, gait training aim is to improve safety, mobility, and independence in daily life for people with spinal cord injury. So this is the form of SCI, FAI. So there's a various parameters, gait parameters, assistive devices parameter, and temporal distance. So we can go through one by one. So gait first is the gait parameter in SCI-FAI, which evaluates six aspects. One is weight safe, step width, rhythm, height, contact, and length. Each leg score from 0 to 10 per item, so maximum score is 20. So higher score, it predicts the better and more coordinated movement. Lower score predict the impaired and dependent gait. Other is assisted device. Score used for the aids like use of cane, walker, A4. If patient not using any devices, we give the 0, means independent walking. Higher is more dependent. The maximum score in this region is 14. The lower score is more independent ambulation. Temporal distance measure, walking mobility score is where and how often the patient walks. 5 is given for the community walker and 0 patient doesn't walk. 2-minute walk test is measure the endurance or distance in there. Higher the score and distance, better function ability. So here we interpret with an example. If a patient have gait parameters is 16 by 20, means there is a mild gait deviation. If assisted device comes 6 by 14, so patient can use quad cane and A4. Mobility score is 4 by face. Patient walk at home and some outdoor mobility. 2-minute walk test comes with the 75 meters. It means patient has good endurance. According to this values, we conclude that the patient has a fairly independent gait with minor deviation, required some support, but is mobile at home and partially in the community. Endurance is adequate, and the patient could benefit from the advanced gait training and community mobility program. Orthotic to support walking function, which is effective and safe and regain walking. Factor which is influence the walking with orthosis. Its injury level of spinal cord injury, upper extremity, lower extremity, motor scores, premorbid activity level, caregiver and its family supports, motivation, household and community scenario, and and also there is a psychological influence is also factor. There's ideal candidate for which one is the ideal candidate for orthosis. Upper limb and lower limb have full range of motion, intact skin over contact with devices without dizziness, while upright meet all the initial rehabilitation goals like bed mobility, transfer training, dressing, and other activities of daily living. So there is a guideline for the long leave brace or the Seffert Center long leave brace. This is the complete checklist. The patient must meet all the following criteria to be considered for long leg bracing, like motivation. Patient express the desire for ambulation with specific and realistic weight. Weight criteria, patient is within 10% of ideal body weight according to your age. Other is a passive range of motion. Means mostly all the range of motion is within normal limits, and there is a no restriction of the joint range of motion. Skin condition: skin must be intact. Cardiovascular health should be have a stable cardiovascular status. And neurological level, mostly spinal cord injury level at T12 or below. Higher level may be considered if all the other criteria are met. Upper limb strength: patient able to perform 15 tricep dips in depression lift with feet elevated. There is a therapy compliance: patient attend all the scheduled physical therapy session. Missing more than 2 sessions may result in exclusion. Wheelchair endurance: patient able to push wheelchair 1 mile in less than 20 minutes. Standing tolerance: able to stand for the 60 minutes parallel bar or standing frame. Must have stable blood pressure, no dizziness, and no sign of joint compromise. Time since injury: patient generally above T12 at least 6 months post injury. Training basis: patient must complete a therapy program in training basis and meeting all set before the prescribing final base. Care availability: a caregiver must be identified for assistance whenever needed. A caregiver name to be documented as also. Functional standing ability: is patient able to maintain a standing position using KFO for a 30 seconds without upper extremity support. So let's talk about the various orthosis in a various different spinal cord injury scenario, like lower extremity orthosis in motor complete SCI. Patient with D8 L3 paraplegic has little no motor sparing in trunk or lower extremity. So we can provide HKFO, which is commonly nomenclature with the hip, knee, and ankle orthosis, which offer maximum bracing stability for the trunk and pelvic control, suitable for the individual with no lower limb movement and generally required walker use, primarily for therapeutic ambulation. Another is the reciprocal gait orthosis. Generally, it prescribed for the above T4 or T12 level, up to the T4 or T12 level, and it is a type of HKFO with thoracic support and a dual cable system enabling the reciprocal leg movement, commonly used in thoracolumbar spinal cord injury, generally T4 to T12 level, and may require significant energy expenditure. There is some other variant like medial linked orthosis and isocentric reciprocal gait orthosis and high energy storage walking orthosis for the improved speed and energy efficient and control. The other is the KFO. It is customized with conventional stance control and microprocessor control system used when hip flexor control is present. Conventional KFO lock during stance. Medial linkage allows swing through gait. Stance control KFO allow passive flexion during swing, and microprocessor KFO enable active flexion, better knee stability, and this required a strong upper limb support, best suited for the short exercise distance or home use, not for the generally not for the community ambulator. Another scenario is lower extremity orthosis and motor incomplete SCI. First is the KFO provide multi-joint stability. Muscle power is less than 2/5 in hip extensor, knee flexor extensor, ankle dorsiflexion, and plantar can be used unilateral or bilateral, typically used with stability aids such as walker or crutches. Second is the AFO provide ankle stability, volitionally control of dorsiflexion impaired or absent, use mainly achieve community ambulator and non-wheelchair. There's a lots of variant of AFO like solid AFO, flow reaction AFO. So there's the indication of that hip extensor is more than equal to 2/5, knee extensor is more than equal to 3/5, dorsiflexion and plantar is less than 2/5. Flow reaction AFO extends support from the tibia to promote knee extension without needing a knee brace. Helpful when a solid AFO alone is not enough and KFO is not indicated. The articulated versus solid AFO. Solid AFO is fixed ankle, used when ankle motion is not needed and contraindicated, and articulated AFO allow adjustable ankle motion, indicated when hip flexor is more than 2/5 and knee extensor is more than 4/5, vice versa. suitable even if active dorsiflexion or plantar flexion is absent. Leaf spring FO is a thin polypropylene or made up of thin polypropylene or carbon fiber, mainly assist in dorsiflexion for the toe clearance during swing phase, minimal to knee control, and indicate hip extensor is more than 3 by 5, hip knee extensor is more than 4 by 5. Some dorsiflexion, frontiflexion are present. This is lightweight and non-articulated. The other is example supramalleolar orthosis is extend from hind foot and encase the malleoli. A function of it is stabilize the ankle and foot, control excessive inversion and eversion, helps reduce spasticity. Indication is muscle strain is more than 3 by 5 at hip and ankle, knee extensor at least 4 by 5. Challenges with lower extremity, lower limb orthosis. What are the challenges we faces? Potentially risk. Patient has a overuse injury like shoulder strain and carpal tunnel syndrome, skin injury with ill-fitting braces, fall due to instability or misuse. Generally, there is some common issues like difficulty in doning and doffing, interference with the wheelchair user, and time-consuming space and assistant limitation. The decondition also be leading to the underuse. What are the technological advances in locomotor function? So one is the overground exoskeleton. So the robotic exoskeleton provides the powered lower limb movement via external frames used for the rehabilitation and personal mobility in individual with spinal cord injury or neurological deficit. Aim is to promote neuroplasticity, mobility, and functional recovery. So what are the key benefits of exoskeleton? It improves the mobility, cardiovascular performance, bone mass density, and leg muscle mass. It also decreases the spasticity, pain, and improve the bowel movement, sleep, and psychological health, and potentially to reduce the complication of the immobility. But limitation is there. It's high cost, around 70.5 to 1.49 crore in INR, in Indian rupees per devices, not widely covered by the insurance, and risk is skin breakdown, fall, overuse injury, and slow walking speed. Clinical versus personal use. The clinical use is rehabilitation center under the supervision, and the personal is home or community setting for paraplegic user. There is some FDA approved exoskeleton devices like ESCO, Indico, Reebok, and Rex. Requirement is the spinal cord injury, which is level T3 and T10 are lower. Okay, and train support person and pass the all the training program module. What are the inclusion and exclusion criteria for exoskeleton? Inclusion criteria is upright tolerance, maintain the skin integrity, range of motion, hip, knee, and ankle is normal. Weight is less than 220 lbs, and height is 5 to 6.3 inch. Ability to follow the patient also cognitively intact. Okay, and exclusion, patient have severe osteoporosis, hypertension, there is any contracture or spasticity, we exclude the patient using this exoskeleton. So there is some exoskeleton devices and their comparison. So there is a 4 FDA approved devices like ESCO, GT, Indigo, Reebok, and Rex. So FDA approved for the EXO, it is for the rehab purposes, Indico rehab plus person, Reebok also rehab plus person, and Rex and EXO is for the rehab. Okay. So training and safety program. Emphasize on the device doning and doffing method, emergency requires like fall training, indoor and outdoors transition, less physical burden on therapists, track gate data automatically for the documentation. Challenges in use is the technical, like limited speed, heavy weight, and functional, need upper limb strength, trained support person, and economically high initial cost, ongoing training and maintenance. Summary and future scope is technologically it is progressing and rapidly with brain-computer interface and spinal cord stimulation under development phase. Further research and cost reduction may improve the accessibility and insurance coverage. Integration into daily use remain a work in progress but hold strong potential. So I'm here showing the some some pics, and there's a site through which you can go through. If someone walk this exoskeleton device, you can go through go through their site. So other neural interface technologies like functional electrical stimulation system used in spinal cord injury with limited lower limb control. Like Parastep, we already see that uh, activates muscle for walking via surface a micro computer stimulation, which help to improve the foot control, ankle stability, and cardiorespiratory fitness. Implanted multi-channel FES is support walking in spinal cord injury patient. Motor neurons stimulated by implanted microprocessor, effective over long-term use. This is the pic of implanted FES. There's a channel of this external controller clinical interference. This is the channel of this implanted FES. So other is the brain-computer interference, which transmits brain signal to the leg movement devices, promising in restoring walking when used with FES or exoskeleton. Another technology is advances is spinal stimulation, like epidural and transcutaneous route, activate spinal locomotor circuit, enhance motor neuron excitability, and walking post training. Early trials show potential to assist exoskeleton use. Transcranial direct current stimulation, it is a non-invasive brain stimulation, may boost voluntary drives via spared corticospinal tracts. Small trials suggest potential when combined with exoskeleton training. And other technology advancement in spinal cord injury locomotion is acute intermittent hypoxia. It is short, low oxygen exposure, boosts spinal plasticity, enhance motor pathway post spinal cord injury. So thank you these are my references, and thank you for your patience listening. And any query you can ask me, sir.
Thank you very much, Dr. Sanyal,
Mm,
for
mm,
your presentation. But things
yes,
are most of the things are on technology based. But
yes, sir. Yes, sir.
how far these technologies are applicable for a common man is a question.
Yeah,
Uh, the first part were presentation very nice about scoring system for predicting the mobility
yes.
of a patient. So both of the example you showed at L3 level motor S1 sensory. So is it
Yes.
applicable for all levels like cervical level, upper thoracic level? Is it applicable for all?
But yes, yes, it's applicable. But for cervical level, we can't predict much walking. But we can predict. We can apply this.
Like
It's
in a
a
case
bit
of
debatable.
ACSC, cervical level ACSC.
We can predict.
So
We can
whatever
predict.
may be the level of neurological level of injury, the assessment will be assessed at L3 level and S1, L3 motor and S1 sensor. Is it okay?
Yes, yeah, this is the point by the Higgs et al. Of three variable prediction rule, according to their three.
So, so it's irrespective of level of injury. You have to
Yes,
see the motor power level score
yes,
at L3 and
L3
sensory score at
is
S1,
S1. Yes, yes, yes,
irrespective of level of injury.
yes, irrespective of level of injury.
Okay, fine. So we'll expect some questions from
Yes,
the
yes. Chat. Oh,
delegates. Let me see. Probability in traumatic and non-traumatic spinal cord injury will be different. Is it considered while evaluating the probability of walking?
uh, sir, chat box. Na? 1 minute, sir. There is a non-traumatic spine will be different, na sir. It's also considered while evaluating the probability in traumatic and non-traumatic. Yes, probability is different. But if we talk about the three variable prediction method, if there is a motor score in L3 level is there, and S1 sensory level is there, and age is there, so we can not much difference of their walking.
So this formula is applicable both for the traumatic as well as
Traumatic and
non-traumatic
non-traumatic.
spinal cord
Yes,
injury.
yes, yes. Both traumatic and as well as non-traumatic spinal cord injury.
Yeah, so most of the things you talked about the all technical technological advances. Do you
Yeah.
advocate those things with the patient having pressure injuries with sacral pressure injury or trochanteric pressure injury? What is your experience? How do you manage these patients in your department? as far as your walking training is concerned, gait training is concerned?
Yes, we can. Yes, sir. First of all, we generally not in our department. We have lack of these technological advances. We already search papers for these technical advancement. But for certain, we generally prescribe overground training with orthosis as well as partial body weight supported treadmill and with braces. We generally kept in mind where is the pressure ulcer. If a patient having pressure ulcer over the sacral region, well padded, well padding before patient going for the locomotor training, and where is the pressure ulcer if there is any contact over the area of this braces or instrument, so we can avoid at the time. Once pressure ulcer heal, and we are not able to manage with the locomotor during the locomotor training, and we are not able to provide the brace, our patient having the some pressure injury like in the heel area, so we generally avoid, we wait for the heel, that pressure injury, then we proceed. If there is a pressure ulcer over the sacral region, we provide the well padding, then we go for the generally prescribe the locomotion with the help of assisted devices, partial body weight supported treadmill, but we kept in mind there is a no pressure over that area. Okay, this much.
Okay. For these advanced technological instruments, they are used for mostly on institutional basis,
Yes,
mostly
yes,
for maintaining the physiological parameters of the body, starting from cardiovascular parameters such as muscle mass,
yes,
bone mass. But
yes, sir.
what we will suggest for the patients when we send back the patient to the community?
Yes, sir. Yes. So generally, we suggest that if after locomotor training done, so basically patient goes with the overground training with the help of these long lead braces like KFO, HKFO, and for the if a patient goes into community, so we think that what the level can he able to walk, so we can go back to our textbook where a patient is able to go into the community with independent walking or use any other sort of ambulatory devices like wheelchair or tricycle or other thing. So depend on the neurological level as well as these braces with the assistive devices uh, universal walker, yeah, auxiliary crutches with the braces. He can community ambulated with the help of these braces and ambulatory aids, but overground training is must before advising for the community ambulation. Institutional as well as home based overground training is important.
Yeah, but in a real sense, if you look, take the questionnaire from the different patients' spinal cord injury. So the study says that also if you see the physiological cost index for a patient with a orthosis long like HKFO or KFO,
Yes,
and versus a patient using a wheelchair or tricycle, probably they prefer a tricycle or wheelchair for community ambulation. Uh,
yes, yes.
so irrespective of level, if it is level is below L3, that's fine. But anything beyond level above L2, they always prefer
Mm.
a tricycle or wheelchair, depending upon their level, for a community ambulation, rather
Yes,
than
yes,
going for any sort of exoskeletal
yes.
orthosis.
Yes, sir. Yes, sir. Absolutely right, sir. In Indian scenario, most of the patient for the community use this use the tricycle and wheelchair for the community ambulator. Here, I am just emphasize and sensitize what other method of the walking. The trends are evolving, and we also look for that. So my presentation for the basically for the postgraduate students who sensitized with these newer technological advancement. Uh, Generally, in our scenario, in Indian scenario, we lack these advances. Basically, uh, what we suggest that if patient are paraplegic Asia A and don't have motor power in their knee, hip, ankle region. So generally, what he use wheelchair, he use tricycle for community ambulation, sir, and we prescribe
So,
this.
so we have to go for a long way for accessing this type of advanced technology and providing this technology at the community level for the patient's spinal cord injury. So
Yes,
still we'll have to depend on the our what are the local resources for training for the spinal cord
yes,
injury so that they can ambulatory in the local level.
yes, yes,
Okay,
yes,
thank you. There is no more questions so far in the chat box.
yes. Uh, yes, sir. Yes, I didn't see, sir, any
Yeah,
other
there's
question.
no questions. Then we
Mhm.
can wind up the session.
Okay,
Um,
okay, okay,
Thank you
okay.
very much,
Thank,
Dr. Sanyal,
okay,
for
thank you so much, sir.
accepting our invitation and
Okay,
presented a beautiful talk, especially recent advances in this locomotor training or gait training for spinal cord injury patients, and the beautiful formula for predicting the ambulatory potential of a spinal cord injury patient. Thank you very much. And I
thank
must
you, thank
thank the office bearer of IAPMR, a special PR team, for providing the Zoom platform for this webinar, academic webinar. And I must thank my colleague of my department and all the members of yeah, Association of Physical Medicine Rehabilitation for supporting us in conducting this academic webinar. Thank you very much and good night.
thank you. Good night, good night.